Contemporary preventive cardiology approaches a chronically ill artery by asking it a single question at a single moment in time. This graph illustrates the problem. Here we have two 52-year-old patients presenting to a clinic today. Both register an identical LDL cholesterol level of 118 milligrams per deciliter. But as we trace their medical histories backward, the identical numbers diverge. Patient A maintained low cholesterol for 30 years and only drifted upward recently. Patient B carried a high cholesterol burden since adolescence and has just begun to decline. By filling in the space under these curves, the difference in total historical exposure becomes visible. These two arteries are in vastly different physical conditions, and no amount of statistical adjustment on today's test score can recover that biological reality. Treating a disease of cumulative exposure based on a single cross-sectional measurement is like trying to understand a movie's plot by staring at a single frame. To understand how risk actually accumulates, we have to look past the clinic and dive directly into the bloodstream. Standard LDL-C tests measure the total mass of cholesterol cargo, but apoB is the outer shell. Measuring it counts the actual atherogenic particles. When container size shrinks, perfectly normal cholesterol mass gets distributed across a dangerously high number of apoB particles. This state is called discordance. It is highly predictable, concentrating in patients with insulin resistance, type 2 diabetes, and high triglycerides, a metabolic profile that now makes up a significant portion of primary care. For decades, this danger was masked by the 1972 Friedewald formula, a standard estimating equation that assumed fixed ratios between particles and cholesterol. That assumption failed precisely in the metabolically vulnerable patients who needed accuracy the most. Prioritizing particle count over cargo mass aligns the measurement with the biological driver of the disease. It identifies at-risk individuals that standard cholesterol estimates often miss. Atherosclerosis begins the moment these apoB particles cross the endothelial barrier and become trapped inside the wall, a process documented as the response to retention hypothesis. Plaque accumulation is a mass action process. Disease severity is driven by the absolute number of particles presented to the barrier and retained over time. In respiratory medicine, a single measurement of cigarette smoke today offers almost no diagnostic value. Lung damage is measured in PAC-years. The cardiovascular equivalent is apoB-years. It represents the total accumulation of atherogenic particles trapped in an artery across an entire lifespan. Since plaque behaves as an accumulating integral, the primary directive of cardiology shifts. The objective is to arrest the forward accrual of apoB-years as early as possible. If cumulative exposure drives the disease, you might expect an apoB-year score to appear on every standard lab report. It does not. Calculating a true lifetime integral requires decades of continuous early life lipid tests. Very few adult patients possess that kind of historical data. This timeline shows a common mathematical workaround known as backcasting. It takes a single midlife test at age 50 and projects a straight population average line backward to age 18. But a population average cannot model an individual. As the line splinters, the margin of error becomes obvious. Individual lipid trajectories fluctuate widely due to weight changes, disease onset, or menopause. Furthermore, the published hazard ratios for cumulative exposure were derived from specific age windows in controlled cohorts. They cannot be lethally or mathematically exponentiated into a lifelong individual risk multiplier. apoB-years is a vital descriptive concept, but deploying it today as a personalized diagnostic score without proper validation is mathematically invalid. Despite the mathematical constraints on individual scoring, the global cardiology establishment is restructuring its approach around this biological premise. The 2026 Multi-Society Dyslipidemia Guideline shifts the focus toward lifetime risk horizons, explicitly endorsing selective apoB measurement to track residual particle burden. Moving this from concept to clinical care requires a rigorous research program. That means calculating retrospective integrals in existing long-term cohorts and conducting prospective imaging trials to link apoB-year reduction directly to plaque reversal. Early intervention data already shows that lowering atherogenic particle exposure halts and can even partially reverse coronary atheroma. The accumulated biological debt can be managed. While the arithmetic of cumulative exposure still awaits final validation, Clinical guidelines are already moving to incorporate this long-term view. The single cholesterol measurement is now being read as one point in the broader history of a patient's lifetime timeline.